right, Amber, if you want to go ahead and share your slides.
Yep. Where did it go? Sure. Can you guys, let's see. Let me get presenter mode or slideshow. All right.
Great to me. Okay, attendees, would you please pop a hello in the chat if you can see the doctor's slides and hear us? It's great. Fantastic. Well, I'm very excited for today's program. Quick intro that I'll give you. My name's Heidi. I think most of you probably know who I am. You know also, if you've ever attended one of our webinars, that if you have any trouble during the webinar, I did send you a troubleshooting email, but certainly feel free to email me and I will do my best to help you. If you come up with questions during the presentation, feel free to pop those in the chat. Dr. Vitalo says that she can grab those as she's going. Very excited because apparently this is a topic that is resonating with the community. We had, I don't know how many of our registrants will attend today, but at least as far as registration goes, we had a record number of 145 people. So big topic, important topic. And I don't know enough about this topic. I know that we're always asking for CPR codes at AERC. And I know Dr. Vitalo is gonna chat about communicating with your clients about this. So Dr. Vitalo has been with us since 2022. She is one of our 5 board certified criticalists at AERC. And you used to be a veterinary assistant with us back in the day, right?
Yep. Yep. In vet school many years ago.
Fantastic. Well, I'm going to go ahead and mute myself and turn off my video, and I'll let you get started.
Perfect. Thank you, Heidi. So as Heidi said, my name's Amber Vitalo. I'm one of the criticalists at AERC. And just as a preface, I want this to be very informal. You know, CPR is a very important topic. It's one we talk about, you know, with owners every day, asking them for a CPR status, whether you're in the ER or private practice. And so all of this information in these slides, which I am happy to share. So if anybody's interested in them, you can contact me or Heidi later on. But all of this information is on the Recover website, which I do have later on in this presentation. And so if you guys have any questions or, you know, comments or want this talk to go, you know, in any other direction, please don't hesitate to either speak up or put it in the chat. And I will be checking in with you guys every so often. I also, you know, am free after this. So if anybody has additional questions at the end or wants to chat a little bit more, I'm happy to stay a few minutes or a little bit later too. So with that, we'll get started here. Let me make sure my slides there. Okay, so we're going to start with just some general information about CPR that you guys probably already know, but I think the most interesting thing about this slide is the numbers on there and the percentages. So on the right, you guys should all be familiar with this, or I hope you have it up in your clinic somewhere, just the basic CPR algorithm. I know at AERC, we have this hanging in multiple places. But if you're doing anesthesia or, you know, sedation, any sort of risk factor for CPR, then this should be up in your clinic somewhere. Early recognition is key. So being able to recognize that your patient is in cardiac arrest is the most important thing, because then otherwise you don't know if you're supposed to be doing CPR. That being said, and while there's limited evidence in animal studies, in humans, they only report serious adverse effects in about 2% of people that receive chest compressions that are not actually in cardiopulmonary arrest. And so when in doubt, my recommendation is just start chest compressions, because the chances of you doing harm in a patient that doesn't need CPR is a lot less than waiting and having the risks of a patient who actually is in a cardiac arrest. The other fun fact is respiratory arrest is a much higher incidence in small animals than compared to people. So the reason our patients are arresting is a bit different than in humans. And so that leads to our survival rates, which I think are really important because we ask owners, CPR or GNR every time they walk through our door. And we don't really think about what happens after that. And so survival is actually very small in small animals. About 6 to 7% of our patients will actually survive to discharge. So even if we get them back, there's a high chance that they arrest again. And I don't think, we have that conversation with owners when we're asking that because it's an important thing to consider. In humans, the survival rate is about 20%. So still not stellar, a bit higher than in animals, but not great. Anesthesia has a higher survival rate. The incidence, though, in animals undergoing cardiac arrest just because of anesthesia is much, much smaller. And so those numbers, like I said, I think are really important to consider when we're thinking about why we're doing CPR, what the animal has died from, and what are the consequences for the animal and the owner. To that effect, we still need to be prepared to do CPR. And so the Recover Initiative was actually initially published in 2012. And there is an updated version in 2024. I believe the first 3 or 4 sections are out. They're still updating things kind of one by one on there. So those aren't completely finished, and they're planning on adding another section about neonate resuscitation, which was not in the original 2012 guidelines. So something to be looking out for. And then, of course, talking to owners about expectations, like I mentioned. And just for reference, it's very similar to the one on the last slide, but this is actually the updated CPR algorithm from the new 2024 guidelines. Not much has changed, and we'll go through all of these steps in detail on the next slides, but excuse me, they did just change their overall presentation of it and making it kind of a little more clear to read. So first, being prepared and trying to prevent your animal from arresting is number one, but being prepared in the event that they do. So this is actually a picture of our CPR cart set up when I was at the University of Florida. It doesn't have to be exactly like this. Our setup at AERC is somewhat similar. But some things, having checklists and going through your crash cart, once a day, or, at least for us, it's once a day. It's part of a checklist. But, if you're not doing it as often, once a week, in your general practice, making sure that you have all the things you need. You can see kind of the labels, but the top door is drugs. And then, of course, we have syringes and needles to be able to administer those things. Then there's ET tubes and intubation equipment. And that may be all you need for a general practice. In a more critical setting like we have in the ER, we have sterile packs to be able to do cut downs or open chest CPR, things like that, which you may not need, in your everyday general practice. Of course, having the algorithm charts or cognitive aids, just so that you guys can see and have things right on hand and not have to think about things. And then, of course, your personnel factors. So high-level training. Your staff needs not just you as the vet, but your staff and technicians need to be trained on how to do CPR because it can be a very fast-moving, nerve-wracking experience if you've never done it before. And so there is the Recover certification that's out there. I highly recommend it. I've actually done it myself as a resident. It was required, but it doesn't take too long. And they're just online courses with some quizzes, and it goes over, there's videos and things. And so you can do it at your own pace, but it's something that if you haven't done or your technical staff hasn't, I highly recommend looking into it because it's really good information to try and be prepared. Of course, CPR is one of those things that you get more comfortable as you do it, but still, having some knowledge can definitely make people feel more comfortable. And then having leadership training. So a person who, on the floor is most comfortable with it. Oftentimes that's the DVM, but sometimes that is a really well-trained technician. And then doing, retraining and updating as things change and debriefing and what can you guys do better after every code. And so with that, we'll start. Sorry, I'm reading the chat, Cassandra. They are on, I have at the end and I can send it, I can copy and paste it into the chat too. There is a Recover Guidelines website. So I have, like I said, I can send you guys the website, but otherwise you can just Google veterinary recover and a website should pop up, and there is all the Recover certification, all of these guidelines, everything is on that website. Hopefully that answers your question. Again, I can send it. I don't want to go to the end of my slides, but I can send it later in the chat, so the link so that you guys have it. Okay, so basic life support, which per the Recover guidelines is defined as administration of chest compressions and intermittent ventilation with the intention to support your cardiorespiratory system in animals that are either don't have a heartbeat or are not breathing. And so the new Recover guidelines are great because they have an algorithm now for every step of CPR. So you can see on this image on the right, you find your patient is unresponsive, you call for help. Oftentimes at AERC, what you'll hear is somebody scream code. And then most of the time you'll see many of us running. And that typically does the trick. And then if you think your dog is, or cat is not breathing or doesn't have a heartbeat, just start compressions. And then the doctor can come and listen. Like I mentioned, the chances of adverse effects, even if they are not completely arrested, is pretty minimal. So what you want to first do is evaluate the patient's airway and see, is it safe to attempt to intubate? Are there any obvious obstructions? Those sorts of things. That being said, this is all done while you're doing chest compressions. I cannot stress that the most important thing you can do early in CPR is chest compressions. Don't worry about intubating or getting a catheter or anything. If you are the first person to discover that a patient is arrested, just start doing chest compressions, and then the other things can happen while you're doing them, because we want to maintain circulation, and that's going to be the most important thing. And per the Recover guidelines, they say chest compressions shouldn't be delayed more than 10 to 15 seconds from discovering your patient has arrested. And we'll go more into depth about the ratio of compressions to breathing and those sorts of things. If you are worried about a patient that has zoonotic risk, of course, do not do any sort of mouth to snout breathing for them. Always prioritize your health over theirs. So to go into the components, of course, first you want to recognize that your patient is in cardiac arrest, either unconscious, unresponsive, they're not breathing or agonal breathing, and of course, they don't have a heartbeat. I would not feel for pulses, because the absence of pulses does not mean that they don't have a heartbeat. And so just be careful with that, because pulses are not a reliable indicator of your patient actually undergoing arrest. Like I said, start chest compressions first, and then we worry about providing ventilation to get oxygenation to the tissues. But if you don't have any sort of circulation, giving them oxygen is not going to do anything. And so the old model of airway breathing circulation has now been replaced with the newer model of circulation, airway, and breathing from there. Because compressions likely have the most significant impact on outcome. And to that effect, just one last note, ischemic injury occurs really fast. So that's why we say we want to get compressions done as quickly as possible. And so with that, chest compressions, form is key. And a lot of the time I find that either people are going too slow, or believe it or not, they're not pushing hard enough. And so the form and your ability to give adequate compressions and providing circulation is really important. And on the next slide, I have some pictures for those visual learners that are out there. But your two main goals of your chest compressions are to restore the pulmonary CO2 elimination, because buildup of CO2 in our body affects metabolism and all those sorts of things. I won't go into all the pathophysiology. And then, of course, we want oxygen getting to our tissues by providing blood flow. Sadly, though, even the best chest compressions only produce 25 to 30% of the patient's normal cardiac output if they were to be alive. And so that is something to consider, and why, even if it's a large dog and resting heart rate is maybe 60, you need to be providing compressions at a rate of about 100 to 120 beats per minute, just because our output is much less. On the flip side of that, you want to avoid going much faster than those, because if you're going faster, your myocardial perfusion, or the perfusion of the heart muscle, becomes much less, because those vessels get perfused during decompression. So when that recoil of the chest is coming back, that is when your heart vessels and vasculature is getting blood. And so you don't want to go too slow, but you don't want to go too fast. And so we aim for that ideal of 100 and 120 beats per minute. And that's why we talk about songs to compress by that are listed there, that kind of, if you stay on the beat, you will be doing about 100 to 120 beats per minute. As far as the position, lateral or dorsal recumbency, most often you'll see them in lateral recumbency, and you wanted your compression depth to be about a third to a half of the chest width, which surprisingly you need to push pretty hard. If they're in dorsal recumbency, which is mostly going to be like your bulldogs or brachycephalic breeds, you want a quarter of the depth at the compression point. Like I said, allow the full recoil. You want to do 2-minute cycles. And I think it doesn't sound like, excuse me, very long, but if you are doing compressions right, you should be exhausted after the end of the 2-minute cycle. It should be hard for you to keep going after the 2 minutes. Your body should be tired. And we need to go the 2 minutes because it takes about 60 seconds of continuous compressions to maintain your perfusion pressure to the heart, and reach a maximum of that 25 to 30% of cardiac output. So if you're switching every 30 seconds, you're not going to be doing adequate CPR because you're not allowing things to build up. As far as the compression form, very important. Lock your elbows with one hand over the other. Some people will decide, so I normally lay my hands flat with one over the other. Some people like to lock their fingers, which is also fine. I've seen people kind of grab onto the fur of the dog or the skin, kind of scruff them a little bit, to be able to get a good grip, which is fine. Unfortunately, they're not feeling anything. You want your shoulders directly above your hands. And so I would say in almost all cases, unless you have a very low table that you're doing CPR on, you need to get a stool or be kneeling on the table or something, because you need your body to be above that patient to be able to do adequate compressions. On the flip side of that, you don't want to be leaning on their chest, because again, you need that chest to recoil back in order to get that blood to the heart muscle. And so looking at these pictures, you can kind of see, like I said, standing on a stool over there on the left with your shoulders aligned with your hands. So very straight, very stiff, locked elbows. Some people, like I said, link their hands together. And then the next slide, I'm going to go into the theories and where you place your hands. But you can see in that middle image, one is showing where that, the image in the middle on the left shows you putting your hands directly over the heart, and the image on the right shows hand position for more of the thoracic pump theory. And then of course the bottom, your brachycephalic dogs, you're going to be right in the middle of the chest, kind of over that xiphoid process area, maybe a little bit above that. For cats and small dogs, there are multiple ways to do this. As you can see, you can do 2 hands around with the thumbs. You can do 1 hand. You can do a fist. What I find is it doesn't matter whether you use 1 hand or 2. What I find the most important hand is that back hand over their back, because otherwise, when you're doing compressions, the animal is sliding away from you. So you just want to keep them sturdy with that back hand so that you make sure they're staying still and you're doing adequate compressions. But honestly, it really doesn't matter whether you're doing 1 hand, 2 hands, whatever you feel most comfortable with. to get the most adequate chest compressions. I find that doing one, I tend to lean more towards the C side just because I have really, really weak thumbs and I can't last 2 minutes. But again, whatever you're most comfortable with. So a little physiology, the models of forward flow. So what are your compressions doing and kind of how is that working in the body? And so the cardiac pump theory is direct compressions over the left and right ventricles. So you're putting your compressions right over the heart, and that pressure increases in the heart, and you're opening the pulmonic and aortic valves for forward flow that way by putting direct compression over the heart and then allowing blood to flow out. And then the elastic properties of the chest allows it to recoil, and that creates a subatmospheric pressure within the heart, and that's what draws blood back into the heart before you do the next compression. Sorry, I just see a question. One moment. Does it matter or change efficacy of compressions if you curl your fingers under versus leave them straight? I would say no. I tend to leave my fingers straight, but some people, like I said, find grabbing on to the dog gives them a little more leverage, or cat. And so I would say whatever works for you. The most important thing is that you're keeping your elbows locked and your body aligned and you're getting that appropriate depth and rate. So however you can make that happen is how I would do it. Hopefully that, but again, this is just anecdotal. There are no studies out there, to show you that. But hopefully that answers your question. So the thoracic pump theory, we're working on increasing the overall intrathoracic pressure during chest compressions rather than increasing the pressure in the heart. And by increasing that intrathoracic pressure, you're forcing blood from the thorax. So basically your caudal vena cava back into the heart. And then as you release up, that pressure change causes forward flow of the blood. And so the heart is acting more of a conduit for blood flow rather than an actual pump. But your approach should be based on the size and the conformation of your patient. So medium to large breed dogs with a round chest, so their chest height width-wise and height-wise is about the similar, and that you're going to aim more towards the thoracic pump theory. And so you can see on the right there, things more like a greyhound or like a barrel-chested dog. You're looking more towards that thoracic pump theory. And so you on the right there, you want your hands up above. The image totally on the right is where you'd put your hands. You can kind of see that the heart is vaguely outlined there, and you want the hands much above that, so more in the center of the chest. And then, sorry, I misspoke. This is more of your greyhound or your barrel-chested dogs. As far as or your fat Labrador, that's kind of as wide as it is tall. For your greyhounds that are more lengthy, where their height is more than their width, that's where you want to do the thoracic pump theory, and you can see the hands directly over the heart. Or the cardiac pump theory. Sorry, I missed speaking. I apologize. If I need to repeat in that, please let me know. And then cats, you want to just go directly over the heart. And then your barrel-chested dogs that, like your brachycephalic bull dogs, those sorts of things that you're putting on your back, there's no way to do the thoracic pump theory just because of how they're laying. So you're going to do compressions over the xiphoid just directly over their heart. Did that make sense? Sorry, I misspoke quite a bit. So if anybody has questions, let me know, but hopefully that's somewhat clear, as clear as mud. So last part of BLS is airway and breathing, so ventilation. And because you want chest compressions going first and ideally not stopped other than that 2-minute cycle, you're going to intubate your patient in lateral recumbency so chest compressions can be performed at the same time. Like I said, if you're worried about zoonotic disease, please do not do mouth to snout rescue breathing. It's just not worth it, because the effectiveness is not known. And so if you know the patient is not a zoonotic risk, fine. It's not going to hurt them by trying it. But the new recommendations also say a tight fitting face mask over the mouth, over mouth to snout breathing. That being said, I think most people, when you're doing CPR, you're in a clinic that has the ability to intubate. So mouth to snout, I mean, I've never been in a position where I've needed to do it, but know it's available to you. You want to breathe at a rate of 10 breaths per minute with a tidal volume of about 10 mils per kilogram or a peak airway pressure of 30 to 40 centimeters of water. And you want to get below 20 centimeters of water between breaths. So it's very similar to breathing for a patient that's under anesthesia or sedated. You want an inspiratory time of 1 second. And if you do have a patient under anesthesia on a ventilator, you want to switch to manual ventilation. You do not want to keep them on the ventilator. You want to have more control of that breathing. And it's really important to avoid hyperventilation or breathing too fast, because then you're breathing off more CO2, which causes a low CO2 in your blood, and that causes cerebral vasoconstriction. And so then when you're doing your compressions, you're actually getting less blood to the brain. And the brain is one of the most important organs that we want to get perfused, especially during CPR. So you're better off to breathe a little bit slower than breathing too fast for your patient. If you cannot intubate the patient for whatever reason, like I said, if you're doing mouth to snout, you do 30 chest compressions and then take a break for a short couple seconds and give 2 short breaths via mouth to snout, and then you go back to your chest compressions. If, of course, the patient is intubated, you're doing this all at the same time. So somebody's doing breathing, somebody's doing compressions, CPR takes an army. So it's not something that can be, or effective CPR is not something that can be done alone or even with 2 people. Oftentimes around a code, at AERC, we have 5, 6, 7 people. Somebody's putting in a catheter, somebody's drawing up drugs, somebody's running the code, somebody is breathing for the patient, somebody's doing compressions and we're rotating every 2 minutes. Somebody's recording everything. So it's not something that is easily done with just a couple of people. All right, so that was basic life support. And I just want to check in and see, does anybody have questions, comments, concerns about anything relating to, chest compressions, those sorts of intubation, those sorts of things. Okay, well, if something comes up, let me know. I know I'm going through this relatively quickly because we only have an hour, and realistically, CPR you can talk about it for days. So if something comes up, I'm happy to go back. So just let me know. But moving on to advanced life support, which is use of monitoring tools, most oftenly an EKG and capnography to guide your CPR. Electrical defibrillation when it's indicated, which we'll go over, obviously getting venous access, and then administration of any other drugs or any other adjunctive therapies that may be needed for the patient. And of course, this is something that can only be performed in a clinical setting, whereas BLS, if for some reason you're volunteering or you're out in the field, that can realistically be performed anywhere. It doesn't take any special equipment. And so you can see the steps of advanced life support down there at the bottom. First, you're going to initiate monitoring. Then you're going to try and obtain vascular access. And once you've done that, obviously, then you can start administering reversals or other therapies. While these are in steps, oftentimes, like I said, we're doing these things simultaneously when we do have a patient that has arrested. As far as the components, I included this, again, visual on your right. We have this on all our crash carts at AERC. If you guys don't have it up in your clinic or have it somewhere, again, this is accessible on the Recover website. You can print it out and just hang it up. It's just very easy for anybody to follow. That way, even if it's not, oftentimes it's not technicians that are pulling up drugs for us at AERC. We have technical assistants and other sorts of things where they can just read this chart and know what to draw up. No math is involved, no brain power. It can be done quickly. You can see all the drugs that are listed there, and we'll go over those in a little bit more detailed. Of course, defibrillation, which oftentimes we don't use very much. And then other things would be like fluids, blood products, electrolytes, blood sugar, all those things, which again, we will go through in more depth in the next couple slides. So as far as drug therapy goes, this is more of a reference. And again, all of this is available on Recover. But your two biggest drugs you're going to hear about are epinephrine and atropine. Obviously, you need to get a catheter in first. If you can't get a catheter in, or you feel like you're not comfortable getting one in a peripheral vein, obviously the animal is arrested, and if you feel most comfortable, put in a jugular catheter. You don't have to do a cut down or anything. Oftentimes they're a bit bigger than your peripheral veins. So try for a jugular catheter, and if you have enough staff, don't be afraid to try in multiple spots. And then when one person gets it, you can stop trying in other spots. But if you can't get a catheter in, you can obviously try IO, but otherwise you can use your ET tube and just give 10 times the recommended dose that was on that previous chart down your ET tube. That being said, you don't want to just squirt it at the entrance or the attachment of the ET tube. It needs to get down into the lung tissue where it can be absorbed. That's the mucous membrane that it's being absorbed through. So you want to use a red rubber and put the red rubber down your ET tube and then administer the drugs down the red rubber. And then since there's such a small amount, always flush that red rubber with like a ml of saline. Otherwise, most of your drugs are going to be sitting inside that red rubber. So if you're doing it by the ET tube, it's not as effective, but it isn't a route that's available. Sometimes if we can't get vascular access right away, we'll start with that. And then once we get vascular access, move down to that. And so like I said, you're going to be looking at epinephrine. So new recommendations are against high dose epinephrine. Oftentimes we're doing low dose epinephrine, and you are giving that every 2-minute cycle, just about. It is a peripheral vasoconstrictor that acts on the alpha 1 receptors. It also has low effects on your beta 1 and 2 receptors, but we're aiming for the alpha at this point. And you want to give that every 3 to 5 minutes. So just about every 1 to 2 cycles. Vasopressin, which is something that you can use in exchange for epinephrine. Oftentimes it's so expensive right now, nobody carries it. So I wouldn't even worry about it. The other big drug that people think about is atropine. And oftentimes I find people giving atropine at every CPR cycle, but it's actually suggesting there's very minimal research out there on atropine. And so it's reasonable for patients with like high vagal tone. So those that have been vomiting or have ileus or your brachycephalic dogs. But give a single dose on your first cycle, and then there's no evidence to support any sort of repetition of it. Just one dose, and that's it. It doesn't make a huge significant impact on the outcome of CPR. Antiarrhythmics you're going to use, depending on, the arrhythmia that's there. If you have a dog that's in VTAC, which hopefully you'd catch before they arrest, but sometimes you can't, you use lidocaine, those sorts of things. But they recommend doing defibrillation first for those shockable rhythms. There's a big controversy out there regarding glucocorticoid agents as far as using them. I only use them if I think the dog is arrested because of an Addisonian crisis. Otherwise, I don't tend to give glucocorticoids. Reversal agents all the time. If they have had any drugs on board, reverse them immediately. Your doses can be found on that chart. Alkalinizing agents, honestly, I never use them. Again, it's a huge controversy. It's only if you've been doing CPR for more than 15 minutes, if your pH is less than 7. those sorts of things. And by that time, if you've been doing CPR for 15 minutes, the chances of you getting that patient back and having them live are very, very minimal. If you have the ability to do like a blood gas or something, electrolytes, so potassium, say you have a block cat that's arrested, we do want to treat that. I wouldn't treat it with bicarbonate. I treat it by more standard methods with like insulin and dextrose or calcium gluconate, terbutaline, those sorts of things. And then fluids, obviously, if a patient is hypovolemic and you think that is contributing, so your severe HGE dog that comes in and unfortunately arrests, and it's probably due to hypovolemic shock, then obviously giving them IV fluid boluses. If your patient's hypoglycemic, supplying dextrose, all of those things. And then this is just again, a CPR dose chart pulled from the Recover guidelines that's available out there as well. Whoops. Okay, so the last part of your advanced life support is going to be electrical defibrillation. It is not something that's used very commonly. And I'll be perfectly honest, I have a little bit of PTSD from this. I actually, as a resident in Florida, had one of my technicians touching the dog, unbeknownst to her, while she was defibrillating, and passed out. And we just went to the floor and we had to call the paramedics and everything. She is fine, but it was a terrifying experience. So the most important thing about doing defibrillation is safety and making sure that people are yelling clear, whoever's shocking, making sure that they are not touching the patient or the table themselves. So just making sure that everybody is instructed and prepared to do defibrillation before you're actually doing it, because it can, hurt your staffing, and it's terrifying when it does. Not to say that you should be afraid of it or not use it, because there are some shockable rhythms out there that you can convert, and sometimes before, the patient even arrests. So your shockable rhythms are going to be ventricular fibrillation, or refractory ventricular tachycardia. And by that, we're meaning that it persists after electrical defibrillation. You completed your next 2-minute cycle and you've evaluated the EKG and there's still no pulse. Bipolar is preferred to monopolar electrical defibrillation based on human studies. There's not any really studies out there on animals. As far as your dose, you're going to go 2 to 4 joules per kg. So start at the low end, and then if it doesn't work, increase by 50% for each additional shock, only going up to 10 joules per kg, because then that's when we start looking at getting harmful to the patient. As far as the timeline, so if you have a patient that arrests and you're noticing they're in ventricular fibrillation immediately, avoid giving any epinephrine first, and try and defibrillate them. That being said, if they've been in arrest for more than 4 minutes, so you're doing CPR, you've done a couple cycles, those sorts of things, and then you notice they're in fibrillation, finish that full 2-minute cycle before you defibrillate them. If you've caught it right away, just do chest compressions until the paddles are ready and charged, and then you can defibrillate. And the reason of this, the recommendation is that 3-phase model of ischemia during ventricular fibrillation. So in that first 4 minutes, they call the electrical phase, and that's when minimal ischemia is noted. And so for the first 4 minutes of ventricular fibrillation, the body has enough stores to maintain cellular energy and metabolic processes. And so that's why before that, if you're less than 4 minutes, you don't just do some compressions and then shock. You're not as worried about perfusion because the body is still able to do its metabolic processes. In the next 6 minutes, so between 4 and 10 minutes, that's what they call your circulatory phase. In other words, you're running out of available cellular energy, and so compressions are going to be really important. And so that's why you want to do your full 2-minute cycle prior to defibrillating to get blood flow to those tissues. And in this phase, the ischemic injury can actually be reversed. Once you get past that 10-minute mark, that's what we call the metabolic phase. And that's when you worry about irreversible ischemic damage. And so again, this is why after that 4 minutes, you want to do the full 2-minute cycle prior to defibrillating, because you need to maintain oxygen delivery and ATP production in the tissues if you want to have a good outcome. Okay, again, I know I'm flying through this stuff, but does anybody have any questions about advanced life support? So drugs, those sorts of things. The next thing we'll talk about is monitoring, and I have some images, but any questions about that stuff, or even back to basic life support? Okay, perfect. Well, if something comes up, just holler in the chat, or you can even interrupt me. So looking at monitoring, really important component of CPR, because you need to know, is your patient coming back? As I mentioned before, pulse palpation, it's pretty useless. If you feel a pulse, great. You know your patient is, has a heartbeat, it's, coming back. If you don't feel a pulse, that doesn't really mean anything. So only palpate between cycles because you need the body to be still. It's not a reliable tool. Take home message, don't waste your time palpating for pulses before starting CPR. If you know a patient is not breathing or cannot hear a heartbeat, just start your compressions. As far as blood pressure goes, not something we measure during CPR. If you have a arterial catheter in place, great, you can watch it, but you're going to get some motion artifact on it. So from compressions and other things going on. So I don't worry about it. But per the Recover guidelines, your diastolic blood pressure should be no less than 30 because that ensures your coronary perfusion pressure of greater than 20. Don't bother with it during CPR. And, we're going to start monitoring it closely after the patient has return of spontaneous circulation. So the take-home message, pulse palpation, blood pressure, not on the top of your list for monitoring. EKG, that's going to be one of your biggest monitoring tools. It does have high motion artifacts, so you really only want to be evaluating it in between cycles when somebody is listening and you're not doing active compression. And the 3 most common arrhythmias that we see in our animal species are asystole. That top one, don't shock that. I don't care what you've seen on TV. Asystole is not a shockable rhythm. It means there is no electrical activity in the heart. And so you shocking it is not going to convert anything. It's not going to give the heart electrical activity. Just keep doing compressions. Ventricular fibrillation, that's going to be the most common thing. So that middle EKG, and that is a shockable rhythm. That is the patient that you want to be considering doing defibrillation on because there is still some electrical activity in the heart. So by shocking them, you may be able to convert them back to a normal sinus rhythm. And then lastly, PEA or pulseless electrical alternans, which is that bottom EKG, which essentially looks like a normal EKG if you look at it. But you won't be able to feel a pulse in the patient. And so it's electrical activity present in the heart, but the heart is not actually conducting positive blood flow because you're not feeling a heart or a pulse. Again, this is not a shockable rhythm. So really the take-home message is the only thing that you're going to shock is when you see ventricular fibrillation, or if you have a patient who's in VTAC who is not responding to any sort of antiarrhythmic therapy. Again, this is another algorithm that's really helpful on the Recover site that tells you when to shock and when not to shock. So something that's easily, printed out and posted, if you guys have a defibrillator, something easily referable to and easy to follow so you can make a quick decision if you're not sure, in the moment. Capnography, which I would say is probably the most important thing to monitor and the most helpful because it is resistant to motion artifact. So once you have the patient intubated, even if you're breathing for them, people are moving them, doing compressions, trying to give drugs, those sorts of things, you should still be able to get an accurate reading. It's also really helpful in determining, are you intubated into the trachea or the esophagus? Because that is important. You don't want to be putting a bunch of air in the stomach. And so if you're getting off, that being said, oftentimes, I know this says if you're getting more than 12 millimeters of mercury on your end tidal CO2, that indicates good ET tube placement. Oftentimes you will intubate a arrested patient and you will get nothing. So the other thing you can look at is their belly. And so what I'll also oftentimes monitor is if the patient is, if somebody's breathing for the patient and their stomach all of a sudden looks more and more bloated, kind of like a GDV patient coming in, then you're probably in the wrong tube because you're in the you're likely in the esophagus and putting all that air in the stomach, and you need to reassess your intubation. Capnography is also a really good indicator of chest compression efficacy. So it's a measure of circulation rather than ventilation because it's measuring the CO2 that's being blown off when you're breathing for the patient. And so that is telling us how much is making it back, how much blood supply is making back to pulmonary circulation for gas exchange. And so you want to aim for greater than 18 millimeters of mercury. And so if you are doing chest compressions and you're only seeing a 5, you're probably not going fast enough, or you're not pushing hard enough or doing an adequate depth. So that's also something that's really helpful to know. And then, of course, you know, the moment we all wait for with CPR is that spontaneous increase, meaning you have return of spontaneous circulation, because now you're getting all that CO2 coming off, which means your cardiac output has increased and more blood is making it back to the lungs. And in humans, an end tidal CO2 of less than 10 over a period of several minutes is a poor prognostic indicator for return of spontaneous circulation. And I would say that that's true in our animal species as well, because the longer you're doing CPR, the longer, you know, the brain is anoxic and you can get permanent brain injury and deficits and those sorts of things. On the bottom of this slide, there was a study in DACVECC a few years ago evaluating the end tidal CO2 as a predictor of return of spontaneous circulation. And they evaluated it during CPR, and it found that it accurately discriminated between getting the patient back and not. So the optimal cutoff was 18. With a pretty high sensitivity and specificity, and it correctly classified almost, you know, above 90% of the cases. So if you're doing CPR and your end tidal CO2 is consistently 5, and then all of a sudden you're at 25, stop and listen for a heartbeat. That's probably an indicator that your patient has a return of spontaneous circulation. Other thing to monitor if you have the capability. So I wouldn't be pulling a bunch of blood to do like a full chemistry or anything like that. But if you can do like a blood gas or an ISTAT or something along those lines. Sodium, you're going to get a wide variation because of fluid shifting during CPR, which you're not going to aim to correct during CPR, but just something to know, especially if you get them back, because fluid shifting, it can cause neurologic injury. Potassium, most commonly I see this in, like I mentioned, block cats that have arrested, or like your Addisonian patient. You want to make sure you're treating that because severe potassium, as you guys I'm sure all are aware, potassium is important in conduction in the heart as well as muscle contraction. So you do want to make sure you're treating that. And then calcium. Very rarely do I treat calcium during CPR. That being said, if the patient is hypocalcemic at less than 0.8, then I will consider giving some calcium because, again, it is a very important electrolyte as far as conduction and contraction of the heart. But there is also limited evidence in humans that hypocalcemia even affects the outcome. So if you don't have access to any of those things, again, not super important. You want to focus on your BLS. And then if you can get a catheter in, you know, reversing drugs, epinephrine, those sorts of things. But these are just extra things that the Recover guidelines go over. And then briefly, return of spontaneous circulation. Clinical signs of effective circulation for greater than 30 seconds. So you'll have a palpable pulse. You're going to get a systolic blood pressure that's ideally greater than 60. And then, of course, again, that most reliable indicator that we know of and easiest to watch is your marked increase in end tidal CO2. And that bottom picture shows what you might see in your capnograph reading, where that large jump in your end tidal. And you interrupt your 2-minute cycle only if there's a sudden and persistent increase in that CO2. So if you see that once and it goes back down, keep going. If you see this and you're getting persistently normal, above 18, 20 end tidal CO2, that's when you can stop and listen and see if your patient is back, and most likely they will be. Okay, so I'll ask questions, and just as I have one slide on open chest CPR. It's not something that's done very commonly, but just so you guys are aware, it is in the Recover guidelines. Your indication, obviously failure of closed chest CPR. So by that, I mean you're doing CPR for 15 to 20 minutes with no success. If they have pleural space disease, pneumothorax, pleural effusion, pericardial effusion, penetrating thoracic wounds, and your huge breed dogs. So your Great Danes, your Mastiffs, or of course, if they're already in surgery, even if you're in the abdomen, you can make a quick little incision into the diaphragm, put your hand through there and start doing compressions. I'll be honest, a lot of the patients were doing CPR in AERC. I would say maybe a good 25% of them should really be having open chest CPR. That being said, if you're moving towards open chest CPR, it needs to be a conversation with the owner, because now you're going into the chest. There's risk of infection. If you do get the patient back, then oftentimes they need to have a full thoracotomy performed, like flushing, closing things up, those sorts of things. So it's just something to think about. And if patients are dying from any of these diseases, the chances of open chest CPR being effective are very minimal anyway. As far as the procedure, you want them in right lateral recumbency. You're going to make an incision over between ribs, like 4 to 6, somewhere in there, on the left lateral side. It's a quick and dirty incision. You're not, if you can clip, great, because it's easier to cut through they have no hair, but you're not doing, a sterile preparation or anything like that. It's quick and dirty. You're getting in there, you're removing the pericardium and compressing the ventricles. Some people will clamp the descending aorta, and the reason that is then you're shunting blood to the heart and the brain, which is the most important. Is it absolutely necessary? No, but it is something that people will recommend doing. Okay. I know we're running tight on time. I have a little bit left, not a ton, but any questions on anything thus far? Okay, perfect. So I think this is probably the most important thing that we don't tend to talk to owners about is post-arrest care. So you're doing CPR on these patients, but then what? What happens after that? It's not, I think most owners are like, yes, do CPR, save my animal. I want my animal back. But they're not going to be that normal pet they're thinking of right after CPR. And I find a lot of people, they watch all these TV shows and medical shows, and CPR looks relatively benign. It's not. It's a lot for the body. If you are not breaking ribs or causing bruises or, things like that, that this animal is going to have to recover from and be painful from when it does come back, then you're not doing it right. And so I do think post-arrest care, while knowing how to do CPR is important, educating on post-arrest care is probably the most important thing you do. As a criticalist, I think most people assume that CPR is something that I enjoy doing and thrive on. And it's not that I don't enjoy it, but I would say probably 85 to 90% of the cases that I'm doing CPR on, I wish I wasn't. It's not super effective. The outcomes aren't great. The patient, even if you get them back, needs prolonged care in hospital, may end up having permanent brain damage, may need to go on a ventilator, is healing from, just the impact of contusions and possible broken ribs. You can cause a hemoabdomen from the compressions and things. So thinking about the consequences of CPR is huge. Even my own pets, if they are under anesthesia and that's the reason they're arresting, great, do CPR because the outcomes are much better because you can reverse the drugs. There's no underlying disease. They're healthy otherwise. That being said, if my animal is not under anesthesia and dying of whatever is going on in the body of its own accord, my pets are a DNR. And so I would say most patients that walk through the door for us, again, we're a referral center, so we're seeing more sick things. My recommendation is that patients are a DNR and we're not doing CPR on these animals that have underlying disease. And the reason for this is everything listed on this slide. So post-cardiac arrest syndrome is reported in humans, and it's defined as multi-organ failure, cardiogenic shock, anoxic brain injury, and then whatever pre-existing disease was present that caused them to arrest in the first place. Because you still have to address that. That doesn't go away just because the animal came back. That underlying disease is still present. But if owners are in it to win it and they want to do things, fluids and pressors for perfusion, you're going to monitor their blood pressure really closely. You're going to try some fluid boluses to get their volume status back. But oftentimes these animals will need to go on pressors. You do want to maintain a mild hypothermia. So like around a 92 degrees Fahrenheit, and maintain that for about 12 hours. And this has shown that it has improved neurologic outcomes in humans. And you want to rewarm them slowly. You don't want to take them from 92 degrees to 100 in a matter of an hour. So I don't go directly putting a bear hugger on these patients. If they're normothermic on their own, I just leave them. If these patients are cold, I leave them and then put a blanket on them. You don't want to be putting bear huggers and warming bags and things like that. It's going to be important to regulate your CO2, like I mentioned before. That's going to be important because of cerebral perfusion pressure and keeping blood flow to your brain. And so normoxemia is what you're aiming for. Most of these patients will either need to remain intubated because they're not awake, and you want to protect their airway, and they need some oxygen supplementation, or they need to go on a mechanical ventilator. And if they have brainstem injury, sometimes it's hard to know right away. And so letting owners know that, okay, great, I have your dog back. It's not breathing on its own right now. That may be a permanent change. If the brainstem has injury, it may come back. I don't know. And it may take weeks to see if this patient is ever going to be back to normal neurologically. You want to maintain hypertension a little bit with arterial pressure of greater than 150, just to maintain, again, perfusion to the brain. That is your main goal. You're going to monitor sugar and electrolytes. And then again, things to discuss with the owners, all these things that I've mentioned. Are they going to be blind? Are they going to be neurologically intact? Do they have a kidney injury, a liver injury? Are they bleeding from the compressions? And then, of course, that underlying disease is still there. And so overall prognosis for these patients is actually very small. And like I mentioned earlier, is less than 5% survive to discharge. And cause of the arrest is the most important factor. So anything under anesthesia arrest has a high as almost 50% survival. So that's much better. But approximately 2 to 10% of dogs and cats survive to discharge, despite having those initial return of spontaneous circulation rates of 35 to 45%. So oftentimes we'll get patients that we get return of spontaneous circulation, and 5 minutes later, they arrest again. Or we talk to the owner, and then the owner is like, I can't do this post-arrest care, and elects to euthanize. So why did we put this patient through CPR to begin with? Or I've had patients that survive and 6 hours later they arrest again. So the chances of survival to discharge are very, very slim. And that's why I think, DNR should be heavily considered in a lot of our patients. And then so here's the Recover Initiative link there. And again, I will put it in the chat at the end. for your reference. And these are just some of the updates that they did in the 2024 guidelines. I went over all of this today, but these are just screenshots of, what they recommend, those sorts of things, and some knowledge gaps that are still left. Obviously, a lot of this is based on human medicine that we extrapolate to animals. And lastly, before any questions, I would just say, don't be afraid to do CPR. If, especially in general practice, I feel like most of your patients are probably arresting from anesthesia or something like that. And this sounds pretty morbid, but the animal is already dead. And so you can't do any more harm. The best you can do, is put in effort to try and save them. And then, I find that even just trying, that can bring comfort to owners. And so don't be afraid. Even if you've never done it before, give it a try. It's a learning experience. Again, the animal is deceased. They can't feel anything. But on the flip side of that, making sure you're talking to owners about, where do we go after? What is this animal enduring? And making sure they're educated on what doing CPR actually means for their patient, I think is really important. And so, again, I know that was a whirlwind and really fast, and kind of hit on the basics. But if anybody has any questions now, or you're welcome to reach out to me anytime, and I'm happy to answer any questions that way as well.
Give folks a second to think of their questions. And again, I will send you a CE certificate for this program within the next week or so. Such an interesting topic.
Think I saw, let's see.
Yeah, it was a recommendations for portable cabinet brass.
I feel like that would fall more under our anesthesia category. I can certainly ask our anesthesiologists. I don't have any. We use the ones that are just connected to like our mobile EKG machines, and those we find are accurate. I don't have great experience with any just like small portable ones, but I can certainly ask around and find out for you if you'd like me to.
That sounds good. And it looks like it was Justine Jones. Justine, if you want to shoot me an email so that Dr. Vitalo has your contact information, then we can follow up on that for you. All right. Oh, there's a question there from Dr. Carver.
For Maria, I see many people doing cat compressions faster than 100 to 120. Can you confirm that the rate in cats or young animals is always the same? Yes, the rate in cats, animals, dogs, big dogs, small dogs, always the same, because you need to have that recoil of the chest to have the myocardium actually perfused. So even if it's a small dog who maintains a higher heart rate, you don't want to do that during CPR, because then your heart muscle is not going to be perfused the way it is. So no matter what, any patient, always aim for 100 to 120.
All right, everyone. Thank you so much for attending today. Thank you, Dr. Vitalo.
You're welcome. Yes, thank you everybody for coming. I hope this was somewhat helpful.
Yep, I'm certain that it was. I'll be sending out CE certificates to all of you. Enjoy the rest of your day.
Oh, wait, does it matter if your pet, last minute question, does it matter if the pet is right or left side down? No, it does not. Whatever is easiest for you guys does not matter. Whatever way the pet is laying is oftentimes whatever way it makes it on the table, just start doing compressions. The only way it really matters is if you're going to be doing open chest CPR, which again doesn't happen very often, and then you do want them right lateral because it's easier to access the heart from the left side.
All right, thank you.